Hello, everybody. Welcome to this week's HSJ Health Check Podcast. I'm Dave West, HSJ's Deputy Editor, and I'm standing in for Annabelle in the chair this week. We are going to talk about the pressing issue of the moment for the health service and for the country, namely the high and rapidly rising pressure in the north of England from coronavirus. And crucially for us, how the NHS is dealing with that and what it means for the health service and the health and care system in the coming weeks and months. Joining me to do that are two of our HSJ correspondents in the north, Lawrence Dunhill, Bureau Chief, who covers the northwest, and Matt Discombe, correspondent who covers the northeast and West Yorkshire. And Lawrence, let me start with you. You've broken several of the stories this week about the rapidly rising pressure on Liverpool hospitals in particular, but also the rest of the north west and how people in that area think it's going to affect them over the next few weeks. Could you give us an idea how, talking to senior healthcare leaders and clinicians in that patch, how they are feeling about how the healthcare system's responding at the moment and how it's going to cope with this period?
Yeah, sure. There's a lot of nervousness about it. They're kind of, Liverpool has got to the stage where they've said they're going to start scaling back their elective programs. I'm not quite clear to what extent that has actually happened yet, and whether patients have actually kind of had cancellation letters or whether they're just not scheduling the sort of same number of treatments as they normally would. But generally they're kind of watching the numbers rise. I think the Royal Liverpool currently is between 15 to 20% occupied by COVID positive patients, and kind of when it starts to get to that 20% level, it sounds like that's the time when a lot of the other stuff is going to have to stop happening, and they're kind of in frantic discussions at the moment with other hospitals in Liverpool, like the specialist ones, Liverpool Heart and Chest especially, and Spire Liverpool did a lot of elective work last time in the first peak, and then there's the possibility for kind of other hospitals in the wider area, like in Halton and St Helens, that are kind of cold sites which could potentially take some elective care out of Liverpool, but then you're kind of getting into quite difficult conversations on a system basis, which that they don't have that kind of solid background of doing that, and it's not very clear about who's in charge of all that and what decision, how those decisions are going to be made. It's very complicated to suddenly move surgical teams out of the Royal Liverpool, for example, and to a site in Halton. There's a lot of kind of work and anxiety that would go along with doing that.
Yeah, we'll come back to the cases, the actual situation with the COVID cases as well in a minute, but give us a bit more of a flavour of that. Is there, presumably they've got plenty of their own stuff going on in Halton, trying to get back to their trust's volumes from pre-COVID elective volumes, and also they have coronavirus cases rising in that patch as well. So I guess it'd be some concern about shipping everything over from Liverpool, and then with all the various technical complexity of that, and then finding themselves caught needing their own capacity as well. Is that?
Yeah, absolutely. Although the rates in the rest of Merseyside aren't as high as Liverpool, and the situation isn't quite as acute there, they are still rising very quickly. And if you're St Helens and Knowsley, you don't particularly want to get involved in taking Liverpool's patients. I wouldn't have thought.
Yeah, it makes sense. They've got their own huge sort of anxieties and pressures. Do you think there should have been more discussion? Back at the end of July and even before that, the NHS was asked from the top to to start thinking about these things, really, to focus on the recovery. But there was various discussion about, well, if another wave comes, the NHS needs to be better able to carry on elective activity, and it's the other stuff it does that's nothing to do with coronavirus. It has huge health implications for many population and patients. And sort of inroads started to be made into designating sites to carry on electives, and the health secretary has talked a lot about splitting blue and green areas, and that's going to kind of allow the health service to carry on a lot better this time. Do you think that the health service, not particularly in that part of the country, but starting there, has sort of failed to do that, if they're now having all these panic conversations now?
It does feel a bit that way. Yes, there were these kind of preparation discussions held in the summer about across the northwest about hot and cold sites, and clean and COVID sites, and separating them, as well as they spent quite a lot of time drawing up plans for new COVID rehab units. No, they were kind of dubbed CCOL units, and they were told by NHS England that there would be some funding available for this, and they spent some time drawing up plans for hundreds of beds, only to be told that the Treasury had said no when it actually came to dishing out the capital money, and so it does feel a bit like there isn't really a new strategy to last time. They're just sort of waiting and ready to go into emergency mode as they did back in March.
And I suspect we'll come back to those issues of how the rest of the health service responds. But just to come back, you talked about the fact that there's these kind of discussions going on, but the actual feeling about the coronavirus cases that are coming into hospitals, are people very much feeling this is like the first wave, or are they saying, what I think probably people have been saying up until the last week is that cases are rising, but actually people are not as ill, and it's rising much more slowly, and we do feel that the health service can cope with this? What's the sort of sense you get from talking to people on the ground?
There's definitely a kind of a quiet positivity that it's not as the surge isn't happening as quickly as last time, and they're much better and more knowledgeable at treating patients. So I think last time a lot more patients got fully ventilated and intubated, because they thought that's what they'd have to do, but then they gradually realized that actually they could treat a lot of people with an oxygen face mask. And so that helps keep the ventilation beds free for the kind of most severe patients. But also there's a lot of fear that this is different because it's winter. There's elective operations going on. Emergency activity is basically back to normal. So hospitals are much more full than last time. Staff are increasingly going off absent as well, which will probably happen even more with the asymptomatic testing, with staff having to self-isolate.
The introduction, the announcement this week that they'll introduce routine testing of asymptomatic staff in the hotspot areas, and the northwest starting to do that this week, so that, as you say, could lead to higher absences. And just that, I mean, it would be interesting because, as you said, emergency activity has been more or less up to where it was before COVID, where it was this time last year. There are sort of small signs of that dropping off, I think, because last time, although the wave one, the NHS in a way kind of gave itself a pat on the back for clearing out 30,000 odd beds to make way for coronavirus, and there was some real impressive work went in there, and lots of kind of behaviour change and policy changes and things like that, funding there. But I think it's probably fair to say as well, a lot of that happened because of individuals' choices to not come to hospital or to go and get their family member out of hospital quickly because they knew what was coming and they wanted to help support the NHS. So it will be kind of interesting and important to see if that behaviour change kicks back in. The health service was helped in stopping doing everything else because everyone else stopped turning up and asking for care, and sort of worked with the health service very much to accept the fact that other things weren't going to be going on. I don't know if there's any slight signs of that in the Northwest yet.
Not sure.
Okay. Matt Discombe, you cover the Northeast and the West Yorkshire for us, which again are other parts of hotspots. Give us a flavour of how things are there this week.
I see. So it seems to be a very kind of similar story to the Northwest, except maybe not quite as bad as cancelling electives yet and what have you. Just to give you a kind of sense of the stats very quickly. I mean, the admissions across North Eastern Yorkshire, West Yorkshire, and Yorkshire, sorry, are climbing. It's between 140 and 180 in recent days, and it's climbing every week and every day. Patients in the hospital are also rising. Last time we saw across the region, about 116 in ventilation beds, went above 100 at the start of this week. Just looking at the kind of comparison between West Yorkshire, where I cover, and the Northeast. Most admissions day to day tend to be in the Northeast, but it kind of fluctuates from day to day, and deaths are the same. Admissions in the Northeast tend to be highest in South Tyneside and Sunderland, Newcastle County Durham. Deaths rising or the highest in South Tyneside, Sunderland, South Tees, and Northumbria healthcare in recent days as well. West Yorkshire admissions are highest in Leeds, Mid Yorkshire, Calderdale, Bradford. That's where most of the 7-day rolling figure of deaths is happening too. So when I've been speaking to healthcare leaders in the Northeast about this kind of deteriorating picture of more and more COVID patients coming in, whilst obviously needing to keep electives going as much as possible, they seem very determined to kind of manage the situation and still maintain electives for now. Although that I am picking up a bit more nervousness about that in recent days from some quarters. And insofar as West Yorkshire, Victoria Easton, the director of public health in Leeds, said hospitals are very close to having to strip back services, and obviously, do you want me to talk about the Nightingales now, or?
Yeah, sure. So as soon as we alluded to, there was I think it was Monday, was it? The NHS National Medical Director, Steve Powis, announced that a couple of sort of interventions in relation to the north of England, one being the testing, which we talked about, and the other one being about the Nightingales in that patch. So.
Yes, of course. So, Lawrence has picked up similar issues, I believe, in Manchester. But I can talk a bit about the issues in Sunderland. We have been told that there's a basic agreement amongst medical directors in the Northeast that the Sunderland Nightingale should only really be used in extremis, and really it's not a suitable environment for patients due to the cold, due to poor ventilation, toilets issues as well. I've heard too, and also staffing as well. Again is a major issue. I mean, there's one chief nurse quoted in Independent today saying that they'd have in the Northeast region, saying they'd have no choice but to stop planned operations if the Sunderland Nightingale is remobilised at any kind of scale. So yeah, huge concern really about the viability of the Sunderland Nightingale just as a concept more than anything.
It seems to me that people are bugged by, a bit like as actually they were in the first peak, by some of the presentation or presentation of what nightingales are, rather than what they actually are in operational terms, because the way it was announced, the announcement on Monday being that they were something like putting on standby over the next few weeks the nightingales in Sunderland, Manchester and Harrogate, which sort of sounds vaguely sensible as a precaution when cases are rising quite steeply, but people, it's accurate to say they're really not much use until you really, really are in a very bad place. So people do not, in the health system, often do not like the presentation of the fact that they actually just there standing ready to help out. And of course that sort of resonates a bit with some of this stuff that's been in right-wing newspapers about, why doesn't the NHS just use these nightingales, in order to keep operations going, and we don't need a lockdown because actually there's a huge Excel centre or a huge Harrogate conference centre there waiting to be filled up with patients. When the reality is, well, they could be used and staffed if the situation was so bad that you didn't mind caring for hundreds of people in a horrible, cold, dark, wet place, and didn't mind diluting the ratios so much that you would have enough staff to do that. But the nightingales, each of the nightingales is slightly different. Is this sort of similar thinking to in Manchester? Manchester, Lawrence, where Manchester was of course one of two nightingales which were actually used a little bit, 2 out of the about 8 or 10 nightingales that were actually used in round one.
Yeah, it was used very, very lightly, and I think it seems safe to assume that unless we see another peak which is bigger than the first peak, then they're not going to be used again. They're just there as a precaution.
Yeah. And you were talking about the Seacoal beds, which was about creating sort of step down capacity for the NHS to help clear out other beds. Is there any prospect of using that was the sort of thing that was going to be the Manchester Nightingale was going to be used for? Is that right, in contrast to the London one, which was sort of the galaxy's biggest intensive care unit?
Yeah, so the Manchester one was always intended for patients who had come off ventilation and were recovering, and I suppose when the Treasury saw this bid for the Seacoal units, that they would have thought, well, you can use the Nightingale for that, and that might be why they rejected it in the end. But ultimately, trusts are still going to be really reluctant to want to send patients and staff there because they just don't think it's that appropriate. But of course, they will do if they literally run out of space.
Yeah, and it does. There's this constant double bind with you can do all these things if you cancel quite a lot of other stuff, or if the patients disappear for quite a lot of other stuff, because then you free up a lot of resources to do that. And let's just come back. You touched on this, Matt, but the feeling in the northeast, from senior people you've spoken to, was that they're more optimistic about being able to keep elective services going. Is that right?
Yeah, they seem to be I'd say optimistic, but hopeful. I'm struggling for the right word, but they seem to be determined. That's a better word. To keep electives open for as long as possible. The kind of influx of patients mirrors a lot what people are saying a lot across a lot of the country, really, in that it's not like the first peak. It's a lot slower, it's a lot more gradual, but it's going up, and it's going to keep going up. So it remains to be seen how long they can keep up electives, and I've certainly not heard that they're anywhere close to doing that yet. But the impression that I've been given is they are determined to keep electives going for as long as possible. But what one, from, as I said, from some quarters, there is a little bit more nervousness over the last few weeks. So we'll see.
Okay, thanks. So it does, strike me that the health service between about June, July, and the end of August spent so much focus on getting elective care back. Then perhaps that was because there was huge focus on trying to get elective planned care levels back to what they were last year, to normal, to start, obviously for the good reason of trying to curb this huge growth in the waiting list that's taken place, and that's going to lead to really long waiting times, and I think will probably be felt for years and years and years in the NHS, especially if it essentially carries on through winter, if we go back to that situation through winter. So good reason there, but I think it did mean that actually the health service stopped doing things, stopped thinking a lot about how it would cope with the next peak. The health service was asked to stop, not particularly to think about the next peak. In fact, it reminds me of one of the daily briefings in the first wave that I appeared on, and this was the early, just when the government was starting to speak about returning elective care, while we were still, perhaps in May, coming down off the first peak, but the health secretary was sort of optimistically talking about getting hospitals back to doing more electives, and I asked the question, well, how can you do that? How many beds are you going to keep free, essentially, in case there's a second wave? And the policy was there isn't going to be a second wave. This was his sort of answer as recorded, as that we won't have one because we've got test and trace and etc. and etc. Now, the health service has never entirely planned on that basis because it knew it was possible that it would come back. But I do think there was a mood at that moment of the health service has been focusing on coronavirus. It's going to focus entirely over there rather than giving enormous thought to actually how it would do both at the same time. I don't know if that resonates at all, Lawrence or Matt.
Yeah, it just most people I'm speaking to just think it's fanciful to think that they're going to get anywhere close to doing the sorts of electives that NHS England envisaged, and I suppose the government envisaged, and this second wave could well be worse than the first because it's come in winter, and so they'll be lucky to be up at sort of doing 40% of last year, let alone up at 90%.
Yeah, electives cancelled in winter at the best of times, or in some of the bad winters, certainly. Let's talk a bit about the asymptomatic testing announcements that Steve Powis made. I've sort of got some thoughts on that from the story we published earlier this week. But you've talked to people a little bit about how that's being introduced in the Northwest, I think, Lawrence. The request was to start it immediately, essentially this week in the Northwest.
Yes, which is, it's quite a tall order because that means thousands and thousands. So I think it's about 100,000 staff that are eligible for it, are the patient-facing staff, and we saw a note that went out to Trust saying that they expect kind of coverage of about 85%. But I don't have enough knowledge of the system to know how realistic that is. But from the few people I spoke to, it didn't sound very realistic.
No, not to do it that quickly. And there's, characteristic of a lot of these conversations about testing just seems ill thought through or sprung on the system, and various people across the north have said to me that it's been met with kind of chaotic responses and scrambling to try and work out what this actually means on the ground, and perhaps more importantly, how the tests would actually be carried out with the testing system running very hot. New figures today showing test results coming back very slowly, and which is as a result of the fact that they're trying to the demand for tests is running very close to supply, too close to allow it to function, and then throwing in 100,000 staff in the Northwest, plus potentially, many people arguing actually they should be introduced nationally. Seems like the Northeast and Yorkshire will come on board, but slightly more slowly. and Jeremy Hunt among others saying that it should be rolled out to the rest of the country. So you're going to getting up numbers getting up towards 1 million. Certainly the high 100,000 people each week adding to the testing demand, and it's not clear how that will be done, and it's resulting in another kind of dispute about who should be expanding testing capacity and how, and why on earth wasn't this done and planned for a few months ago. But we should also perhaps just touch on other parts of the country. I don't know whether you keep an eye on the figures, Lawrence, of you, and we were speaking on Thursday, having heard that London and Essex and York are being moved into tier 2 of the government's lockdown policy. But I wondered if you, Lawrence, sort of could give us an update on how the COVID cases in the healthcare system are going in the rest of the country. Sprung that on you. I can never go myself if you prefer.
COVID cases in hospital? Or?
Yeah, hospital impact and death and mortality.
I must admit I've been a bit just obsessed with looking at the Northwest figures, so I'm a bit about the rest, I must confess.
Yeah, I see. I mean, it looks to me like the Northwest and the Northeast are sharply, distinctly above other places. West Yorkshire is fairly close in behind, isn't it, Matt? And then I think it looks to me like South Yorkshire is now coming up quite rapidly in the last few days. And then other parts of the country. There's some parts of the Midlands, West Midlands, where this is a sort of lower, and actually not growing quite so dramatically quickly as the North. But there is a notable growth in parts of the West Midlands and East London in particular. The rest of London's not so substantially affected, and I think perhaps a little bit in Hertfordshire, and perhaps there seems to be concern in Essex, seeing as Essex being put into tier 2 and is very close into the conurbation with East London, and the Barking, Havering and Redbridge Trust in particular seeing a lot of admissions and mortality, I think. But I think that probably brings us to the end of this week's episode, and we'll be back next week with probably an update on this subject and perhaps talking about some other things as well. So thanks very much for listening. We will speak to you soon. Goodbye.